Hi, my name's Peggy Cooney, and this is my colleague.
Hi, I'm Larry Picard.
Today we're going to be talking about harm reduction, finding approaches that work with resistive clients.
So harm reduction, what is it? So it's really that approach that, if you will, that focuses on reducing harm rather than reducing behavior, and that's a really important point. At the same time, it promotes equal human rights, and it seeks to reduce social and other healthcare disparities, if you will. And that focus on human rights really places harm reduction right in our adult services ball court, right, Peggy?
Great, yeah, absolutely.
It also seems to empower clients to advocate for themselves. So here we go with, our commitment to the right to self-determination, which is, right in the heart of what we do. And research has shown that it can actually reduce harm and promote the quality of life and even decrease high-risk behaviors, if you will. So the quality of life issue is really at the apex of harm reduction, and I think also for adult protective services as well.
And one thing I love about harm reduction is that it really gives back a sense of control for our elders. It seems like as we get older, they take away our license, they take away things, and just not having that sense of autonomy, harm reduction really speaks to that to me.
Yeah, and I think a lot of elders really are very resentful when people try to sort of swoop in and try to take control.
I know when you told me to do something yesterday, I didn't want to do it.
Oh well.
So what do effective helpers need to know? So we're going to look at some helpful assumptions and principles, right? Behavior change is very difficult.
Yes.
We can't rush it. Clients do want to change, but not necessarily the change you and I want to see. And the relationship is the most important piece. As long as there's a relationship, there really is a chance for change.
Yeah, I think, also, the whole business around whose change is it that we're talking about?
Right,
is it our change as an adult protective service worker, or is it the family member, or is it the neighbor, whatever the case may be?
Right.
So why is behavior change really so difficult for the clients we work with? Well, in many instances, the behavior actually meets some sort of a need.
Right.
I mean, I think probably some of you can reflect on hoarding cases, for example. And in many of those hoarding cases, the elder, for whatever reason, has a system, if you will, in their mind that this hoarding, whatever it is, animals, paper, whatever the case, meets some sort of need. The behavior may also have been adaptive, if you will, at one point in their life, and now it is not adaptive, but the groove is worn.
I like that expression.
Yeah, and then we've talked about this, right? There's this cycle of guilt and shame that occurs, right?
Right.
Yeah. And then, of course, big change for a lot of people, even us, right? It can be overwhelming. So if you're alone, you're isolated or whatever, you have a lot of disability and so forth, that the prospect of having to change all of that can be completely overwhelming.
Right.
Yeah.
Totally agree.
And there also, of course, can be, co-occurring disorders. Many of you know already that in APS work, we may have a client that's demented, but they also may be suffering from some severe psychiatric problem, or they may be some addiction problem, whatever the case may be.
Yeah. How does it work? How does harm reduction work? So, again, addressing the basic needs, beginning where the client is, right? And again, I can't emphasize enough about how important relationship building is. So again, coming from a rural county, relationships were kind of the thing because we didn't have a lot of resources, right? So remembering who the expert on the problem is and whose problem it is. It's not our problem, it's their problem. Developing an anything goes attitude towards the client, some change is good, right? And so we really look at baby steps. And then exploring options rather than prescribing, not telling people what to do, but maybe to agree on what risk actually looks like, and then saying, how are we going to get there? How are we going to make it better together, right? And then motivational interviewing skills are key.
Yeah.
Okay, so that it's a therapeutic approach.
Right. So we'll mention motivational interviewing here, and also we'll conclude with this. We're not going to expand on it, but we want to point to it because we feel that it's a critical piece an approach that can be used in adult protective service work, right?
Right.
For helping clients. So it really helps clients regardless, if you will, of their readiness to change.
Right.
And do we have any of those clients at Adult Protective Services?
Never.
Right, exactly. Never. It can also be seamlessly integrated into other kinds of interventions. It's not just a separate sort of intervention.
Right.
And it works in all types of areas. So, and actually really, MI or motivational interviewing is to help clients that are stuck, that really can't move on,
right,
if you will.
So there's advantages to harm reduction. It keeps the provider-client relationship alive. It's very pragmatic. Mm-hmm. If adherence isn't realistic, something else is, right?
Right.
What else can we do? You can feel really good about smaller successes, and I think, again, this field of adult protective services can be pretty traumatic for the elders as well as the social workers. So to take it in small steps makes such a difference.
And I think, from your standpoint as workers, even the simplest act that you do, the simplest intervention can be monumental in terms of the elder. Just visiting for some, especially
right,
like in rural areas, right, where people are totally isolated.
Oh, for sure.
You may be the only contact. The worker may be the only contact.
It eliminates the tension that exists between providers and the non-compliant client. It liberates the provider from responsibility for the outcome. And it focuses on the process, not the outcome.
Right.
So what else can we try?
Yeah.
This didn't work, let's try something else.
Yeah, exactly. So there's a basic reduction or a harm reduction philosophy that exists, and the guiding principle for providers, it really is that it focuses, as we mentioned in the beginning, right? It focuses on the relationship and not necessarily the outcome.
Right.
And many times we're asked to point to the outcome. People want to see certain things happen. They want the house with the papers stacked outside and the cars in the yard and the washing machines on the front porch to all be gone, if you will. So it also recognizes that the behavior change, of course, is really difficult. We've said this before as well, and it may not change actually according to our plan. And of course, in APS, we have to have a plan. So the important thing to, I think, remember there is to be flexible, right?
Oh, for sure.
Plan. And it changes how the issue of responsibility it's really factored in, if you will, into the treatment equation. And when we talk about responsibility, whose responsibility are we talking about?
Right.
Yeah.
Not ours.
Exactly.
So,
it's the client. It's the client. Totally.
Great. So our harm reduction that we're talking about today is really built on a model by TATARSKY in 2002. Again, we're meeting the client as an individual. We start where the client is, assuming that the client has strengths that can be supported, what's worked in the past, and let's do more of that. Accepting small baby steps that we talked about before. And the most important thing about the model to me is not holding abstinence as a necessary precondition of the intervention before really getting to know the individual. So developing a collaborative, empowering relationship with the client. Again, we can't say relationship enough. And the importance of destigmatizing substance abusers. Although harm reduction was originally and most frequently associated with substance abuse, it's increasingly being applied to a multitude of other behaviors, including alcohol interventions, nicotine replacement, and now one of the bigger issues in the United States, opium substitution. So it just provides interventions and additional tools for clinicians working with this population for whatever reason may not be ready or willing to pursue full abstinence.
Yeah, you and I were talking the other day about this business about destigmatizing substance abusers.
Right.
Rather than, oh, well, she's just or he's just another alcoholic.
Right.
Or, another drug abuser, whatever. But to see them in the light of, they have an illness essentially, right?
Yeah, and their behavior's creating a risk.
Exactly.
So we focus on the behavior and not the alcoholic or addict.
Exactly.
Right? Great.
Exactly. So a part of the harm reduction model is to meet the client as, of course, an individual. the clients come with a whole set of their internal worlds.
I call them onion layers.
Yeah, that's really a good analogy. Yeah, totally. They have their strengths, they have their needs, of course. They're vulnerable in certain areas. They have their own social backgrounds and their own histories. Actually, I think that's what makes our work so fascinating, is the history that a lot of the clients bring, right?
Yeah.
When you're doing your assessment, you find out all these things about clients. So because of this, the patterns of use, you will, and the meaning of these that are held by the individual are quite unique. And so our task is really respecting that and honoring that in a way that we can. At the same time, be there for them as hopefully they make those steps towards change. So the service plan really needs to be tailored as close as possible, if you will, to the individual client and what their needs are.
Right. What does it mean to start where the client is? It means that at least initially, the social worker must forego judgments and listen carefully to discern what the client is feeling and thinking about, and not to step either too far away or to move too quickly ahead where you think the client needs to be at. So I call it that walking in every day with an empty bowl. That each client has their own story, their own unique story, and if we come in with an empty bowl, then we're going to listen to that particular person's story, and our service plan with them will be unique and different from another person who might have at first seemed like they were identical cases.
Yeah, that's a beautiful way of putting it.
Thank you.
Yeah, for sure. So, of course, the goal in harm reduction is to support the strengths. And clients have many, many strengths that can be mobilized for positive growth, if you will, and change. And the strengths, there's actually a model in social work practice called the strengths perspective, if you will. So, and some of our clients come to us wanting to feel better and may lack the energy and motivation, and part of us is enabling that for them, if you will. They may also have a self-reflective part that brings their capacity to learn something about him or herself, so we're searching for that in this model. And clients may also be willing to take risks when we didn't ordinarily think that they were. They might be interested in taking some risks to change from this groove or rut, if you will, that they've been in.
Right. Again, accepting small incremental changes as steps in the right direction. This is true client-centered practice. You need to be content with small steps. That's all life is. And small steps that you take every day, so when you go back down the road, it all adds up and you know you've covered some distance. One of my favorite quotes from Katie Kavinsky. And harm reduction begins with engagement as a priority. Humans have an ingrained opposition to being forced, right, Larry?
Yes, indeed. Indeed. And we see that a lot in APS work, right? Yeah. So a part of the model as well is to develop collaborative, empowering relationships. So traditional interventions with self-harming behavior, which is what we see often with self-neglect cases and so forth, can be viewed and have been viewed in sort of a patriarchal framework. So the provider then, in that framework knows what's best for the client, the addict, the alcoholic or whatever, and it's assumed that you cannot trust him or her to actually carry through or be a part of the plan. Yeah. To that end, the addict, if you want to use that as an example, is supposed to see the provider as having the greater wisdom. And we know how that works.
Right.
It doesn't work oftentimes. So with harm reduction, there's a tradition of the quality, if you will, in collaboration between the provider and the client.
Really getting them to see what's in it for them.
Yes,
so
exactly.
it's not our motivation, it's their motivation. So if you can figure out what that motivation is, that's when you start to move forward.
And don't you see teamwork as being an essential part
Absolutely.
of it? Yeah, it's very much so.
Sometimes we encounter difficulties when trying to help substance abusers because of negative assumptions we make about them. You talked about before, calling somebody an alcoholic or calling somebody a drug addict. The words we use matter. When we talk about people with words like crackhead, alcoholic, we dehumanize them, and they may be struggling, right? So we need to always focus on the behavior and its impact and refrain from judgment.
For sure. We also need to understand the factors that are, of course, unique to each client. So what is the function of that resistant behavior we may be seeing, right? How does the client's current resistance fit into their developmental or historical pattern of resistance? Is this something new, or is it the way they've always acted? What might be some of the client's, like idiosyncratic beliefs that are feeding, if you will, into their resistance? And what might the client fear? Because often I think fear is a big factor.
Oh, for sure.
Yeah, people don't want to change because they're
sure.
fearful. And how might the client be characteristically misunderstanding or misinterpreting, if you will, what our suggestions are? So how are, reflecting? How are they hearing us?
Right.
Yeah.
Especially if they've had a negative experience with a social worker in the past, that you may have to work a little bit hard at that relationship piece because they've had a bad experience and just don't trust you.
Right. And part of that, of course, is to be tenacious and patient.
Yes.
Because it doesn't happen overnight usually. Yeah.
Definitely two qualities APS social workers need to have.
Yeah, for sure. And so then what skills do the clients, what do they actually lack? So it's an identification of what the needs are, and how can you collaborate with them in providing services and or facilitating for them these skills that they need to solve the problem.
For sure.
Yeah. And then lastly, what factors are in the client's environment, if you will, that may be really not working to the client's benefit, in fact, sort of punishing them from achieving the goal of change?
So interventions for increasing clients' motivation, we talk about educating the client about therapy. And again, I even be careful to talk that way, kind of a step down sort of using the Socratic method, which is a form of inquiry and discussion between individuals based on asking and answering questions to stimulate critical thinking and to illuminate ideas. Providing the client with choices and an active say, collaborating and compromising, reviewing the pros and cons of change. That's always really great to do with elders, and continuing with the psychological. What are the pros and cons of continuing with the psychological status quo?
And
right?
reviewing the pros
What's
and
in
cons.
it for them?
Yeah, totally. Yeah.
And then providing accurate empathy for the client's resistance. Wow, you've managed to make it this far. And I can't imagine how you've been able to do that. So really joining with them to have empathetic responses sometimes can motivate an elder into action. And then discussing the case conceptualization with the client, speaking their language. For God's sake, I just learned that 25% of elders in the United States have some issue around literacy. So if really kind of talking in their particular language is so important is to feed that back to them. And then maximizing the use of client self-direction. Again, we talk about autonomy and their ability to make their own decisions as safe as it can be. And then being gently persistent when a client's stuck. And that's really where motivational interviewing comes in.
Yeah, persistent and patient, right? Yeah. So, we're going to conclude with just to reiterate that motivational interviewing is really a way, if you will, of being with the client. And it's not just a set of techniques for doing counseling. So it is a technique in which you become a helper in the change process, if you will, and you express acceptance of the client. And it's a way to interact with substance abusing clients or self-neglecting clients, whatever the case may be. And it's not merely just an adjunct to other therapeutic approaches, but it's a style of counseling that you can employ. So it builds on Carl Rogers' optimistic and humanistic theories about people's capabilities for exercising free choice and changing through a process, of course, of self-actualization. And really, if you want to sum it up, it is a democratic partnership. And Peggy and I encourage you to look into motivational interviewing as a tool that you can really use in APS work. And we also hope that you've enjoyed this presentation on harm reduction, and it will be helpful in your practice, right?
Yep. Thank you.
Thank you.